Just a curious question about TB and COVID pandemic. Using mask, social distancing, and washing hands as hygienic habits among population, will there be any change in TB transmission at community level? So this was the question by Suchata. It is a general question. I don't know for whose presentation she was asking. So I think it is both the way. On one hand, the mask has actually increased the the health-seeking behavior or preventive measures, especially in India. We could literally see that this is a huge change in that is one positive thing about COVID is the increasing in mask has actually increased, and there must be some study at least at the household level or at the hotspot level to understand how it has impacted the transmission. On the other way, COVID has also increased the socioeconomic inequality, and then it has also decreased. The notification has fallen so much in 2019. Yes. So, it is also going to create the problems. So it is two way we have. So there was a dissemination meeting before some 10 days. We had a TB Free Chennai project, and there was a presentation by the Stop TB co-chair, Dr. So he told they conducted a modeling study. So based on the lockdown impact in 2020, what they have projected is between 2020 to 25, there is going to be additional 6 million new cases, and there is going to be additional 1 million TB deaths just for the 3-month or 6-month scenario of lockdown. Such is the impact it is going to have. And then the global TB elimination or the progress, whatever we have achieved, is going to be delayed by another 6 or 7 months. That was the projection made for 2020 delay. And right now, we are facing another huge second wave now. No, it will be a cumulative addition. So the COVID and TB itself is a huge topic which has emerged, which has created a lot of challenges for us. That is the thing. So I would request the participants, we can keep 2 or 3 questions, and the remaining we could leave it. I think the presenters could put their email IDs in the chat box. If anyone can have the doubts, we could also respond. I also request if there is any questions from Sonar side. It is an Indian side presentation. This will be a new thing, a new kind of knowledge we have disseminated from our side. Especially the Sonar has been doing a lot of works on community engagement approaches, and then you will be finding KHPT has done a lot of works on community engagement and community structures. That might interest you. If you have any questions, you can post up, you can put it in the chat box. And especially I have 2 things I am very impressed with the pediatric counseling tool of MSF. If you could share with us, if you have a pediatric counseling tool, because that is something which is very much missing, the special focus towards. We have adolescent counseling modules for HIV, but such a thing has not happened for TB. So it will be a great thing for us, cartoon-based, things that will be useful for us. And sure. Yeah, that will be thing. And Dr. Karuna has highlighted the stigma-related problems. We are keep on speaking about stigma, but still it is a very, very structural problem. I could say that half of the problems could be attributed to stigma. And I am very interested to see such a long longitudinal study with such a number of samples has been conducted. Almost 4,000 has been followed up for almost 6 to 7 years. That is a wonderful data which we would like to know more about. And then KHPT, they are our partners. I know very much their work, excellent work they have been doing. And then, all the 3 strategies given by KHPT, the differential care approach, patient-centric approach, and community engagement models are really excellent. And I think they are in the pilot stage right now. They will be expanding to the program that could be utilized by all the participants. They have a lot of materials also in their, website that will be of use, I feel. And of course, Dr. Muniandi, my HOD, he had made a very elaborate presentation. Dr. Muniandi is the only health economist right now in ICMR-NIRT, and he is a TB special economist with more than 100 publications. He has done a length of studies starting from 1997 till date. So that he has also summarized the economic components of TB in a very nice way. So this session was very productive. It was very, very engaging. It was very, very informative. Thank you for all the presenters. So let me know if there is any 1 or 2 quick questions. Otherwise we can go to the next wrap-up session. About laying forward. Even if the presenters have some other doubts or clarification from other presenters, they could post the question. Especially, I want to hear at least 1 question from the participant side. We still have 52 participants.
Dr. Kari, I think in the chat there's a question to Dr. Aparna about ensuring participation in patient support groups. Sorry, my chat is moving all over the place. About how's that done digitally, how that's done remotely, I think. Sorry, I'm having...
Thank you, Christopher, for sharing that. So actually, it was a challenge initially, but our team of counselors identified all those patients who had WhatsApp, and with their consent, we could, share the number of members in particular group. It was a small group, but based on those, like 4 or 5, we could include them in the WhatsApp group calling and to do those chats, and that was possible through that.
Wonderful. Great. And there was a question. Yeah, please.
A bit further down, there is also another question to Dr. Karuna. I just want to know your thoughts on MBY. Why do you think that DBT doesn't reach the TB patient even though it's structured and formulated well? Dr. Karuna still here, or?
Yeah, I am here. I'm here. So I was just trying to find a question. So this is on the NPY, isn't it?
Yes, I can post it again, but otherwise you need to scroll down.
Could you just repeat again? I'm sorry.
Sure. I will post it and I will read it.
Great.
This person just wants to know your thoughts on MBY. What do you think the DBT doesn't reach the TB patient, even though it's structured and formulated well?
So there are two both provider-related and patient-related issues here, because it was initiated in 2018. So it is a recent scheme, and then program is still getting hold of how to operationalize it. There have been guidelines. In fact, the DBT process, our union office in this Delhi supports the program in financial management system for this, for direct benefit transfer. So what we found was that people who are doing this in the program are the same health workers. So there is no additional staff or any specific focal point for this. So whoever is there, whether it's a treatment supervisor, they have a CADAR, like senior treatment supervisor, who generally monitors the patient and who visits the patient for contact tracing and things like that. He or the data entry operator, they have to link the bank details of the patient into the NICSIA. NICSIA has, which is the database, national database. It has to accept the bank details, then only the money goes. So there are a lot of challenges here. Sometimes bank details are not entered properly. There could be a lot of errors while entering itself. And then it comes back and they have to figure out what went wrong. So, and sometimes patient provides wrong bank details. The patient bank details are not linked to a national identity, national social identifier card that is given, that's called the Aadhaar. So the account should be Aadhaar linked. So if it is not linked with this, that account they will not send the money. So these kind of operational issues actually add on to the existing burden of the health worker and patients also. After they get their medicine, they continue to follow up with STS and others, but then since they don't get proper response, sometimes health workers are busy, so they don't anticipate much response, so they just keep waiting. And this whole thing adds on to the cumulative burden. Many patients have reported that they got the entire amount at the end of the treatment. So for me, the point is that the purpose is defeated, because while on the treatment, this man did not have enough food to eat. So our vision of having this DBT is that they will have food to eat and they'll be able to have proper outcomes of the treatment. But then that cannot happen unless it is dispersed on time to the patient. So there should be alternative ways found, or there should be an exclusive cadre of people who will provide this social support and not who are not handling other medical aspects of the TB. Like say if it is a counselor who can also do counseling, but who can also handle these kind of additional duties, which will save a lot of time and burden and disbursement can be ensured on time. So we have to understand the workload of the health service providers, not keep every scheme that comes, you push on the existing staff. We keep on pushing them with overburden. And similarly, the frontline health workers who are the dot providers also in community are, we have ASHA workers. Any new health scheme comes, it's on ASHA workers. And this is not only for TB. ASHA workers are the accredited social health workers who are based in community, and they handle all health programs, maternal health, child health, vector-borne diseases, HIV, TB, whatnot. So those people will not have time to follow up with patient whether they got the money or not. So I think we need to look at this workload, and also why it should be always Aadhaar linked, because they have made it mandatory. Any benefit if any citizen of India has to get, they have to get only through this Aadhaar linked. While there is a judgment from the Supreme Court that it doesn't need to be, but we still have this in the program. Can we make it, can we look at it and see that it is not mandatory? Then most of the people might be able to get. Or is there is no possibility of cash reimbursement? That is why this mechanism is in place, but this has a lot of challenges. So one of my suggestion was the PDS system should be explored, where we can provide much better support. Like Dr. Aparna also suggested that we should have to have more support. 500 rupees, which literally translates to $7 per month, is not going to provide nutritional support for one adult for the entire month. It is just sometimes it is very token, a small token. Though people who don't have money, when this comes, it is a real joy for them. I have seen patients who were so happy to talk about this, and they were like, ma'am, when all the money came, though every month didn't it come, I got 3,000 at one time. I was so happy. So I could see the joy in their eyes. But then for me, as a third person looking at what is their nutritional need, their BMI is so low. What is this 500 going to add? Are they going to buy vegetables? Are they going to buy milk and drink for themselves? Or the children are hungry? Are they going to give to the children? So this, I think, needs assessment based. We have to see, and it has to be amount definitely has to be better than this. And I also want to highlight here that this support, okay, this nutritional support is for all TB patients. Now that is again a place where programs should look at. I'll tell you, my friend who is a medical doctor who has a government job, she earns almost 2 lakhs per month. So when her aunt got diagnosed with TB, she also received this 500 rupees per month. So my question is, somebody who is in a very good economical position, they don't need this 500 rupees. But somebody who doesn't, who is the only breadwinner in the house and he is affected, they need. So instead of giving money for that 500 rupees, distributing it for all the people, there has to be concentrated approach in this nutritional disbursement. Rather giving 500 to these people, give 3,000 to that one person who is actually in need. That will make a lot more difference in that person's life. So these are my views on the
Thank you.
Mixture Poshan Yojana. Thank you.
Thank you, Dr. Karuna. So do we have any other questions online? I think, Chris, I think we have read all the chats. I think there are no more questions, right? Yeah. So is there anything from participants online, or we could take maybe one more questions and then we can go to the next, wrap-up session. Okay. So Chris, can I proceed for the next one?
Yeah, I think so. I think Tamara is here as well, Dr. Kari. I think I was just going to make one quick point about the community engagement. I thought that was you've obviously made that connection between with the work that Sonar's doing, and this will hopefully follow into Tamara and you're wrapping up. But I think the people who are directly engaged with Sonar's work on community engagement are not present today. But I think that would be very interesting to link them up with the work that's been done, the TB-related community engagement work that you've been involved with, or that colleagues have been involved with.